Thank you, Lord, for the gift of life that you've granted unto us. As we're going to start the session of this afternoon, we pray for your guidance so that we're able to understand and remember what we're going to discuss. And during exams, we pass, and all the glory and honor will be back to you. In Jesus' name I pray. Amen.
Okay, thank you, Cindy, for the prayer. I would like to have someone to for the questions. I have Rubikesh for the score sheet. Let me have someone for the questions. Someone to update questions for us. Yes, a volunteer. Nipate mtu wa maswali haraka, tuanze. Yeah. Mtu wa questions. You have Sharon for the questions. Thank you, Sharon. Gal Toto alikuwa pia amejitolea. Gal Toto, wewe utatupea evidences. So tukihitaji evidences, unajua Gal Toto got us. So we can start Rubikesh tutamshia hapa score sheet. Net ikisumbua utanisaidia. Okay. But we hope net haitasumbua. Gal Toto utafutange evidences. So nikihitaji evidence nauliza copy Gal Toto. Yeah. So Rubikesh nipe score sheet. Give me the score sheet hapa. Yeah, wow. We have the score sheet here. Let me have the questions. Sharon, we are to start from question 373 of the KRCHN PP1. Let me have those questions, Sharon. Hata hiyo net ishaanza. Oi, noma. So Galtoto, unaweza saidiana na Sharon about the questions to make sure they are available at every time we need them. Yes. And we are starting from question 373, and from question 373 it says you assess a client with newly diagnosed hypothyroidism as having an enlarged thyroid gland goiter. What pathologic process causes this enlargement? You assess a client with newly diagnosed hypothyroidism as having an enlarged thyroid gland, that is goiter. What pathologic process causes this enlargement? A. We have an excess TH stimulates thyroid follicles. Then B. We have an increased dietary iodine intake. C. We have a compensatory effort to produce more TH. Then D. We have tissue hypertrophy in response to increased TH. So let me have people tackling that question. Let me have people tackling question 373. We have Dopa going with C. We have Finn going with C. Morphine, but okay. Then we have Naskimu is going with A. Chero going with C. So people are going with C and A. C and A. And A reads an excess of TH stimulates the thyroid follicles. Then C reads a compensatory effort to produce more TH. So let me get some evidence. Where is Galdoto? Let me get some evidence. Some evidence on hypothyroidism. Yes. Win-win is going with C. So people are endorsing both C and A. I believe we are very many in this chat. We have 70 participants. I expect now we have 67 participants. I expect to have a good turnout when it comes to endorsing the questions. Please, yeah. So let me get some evidence. Let me get some evidence. Ama nijitafutie evidence. Where is this evidence? Endocrine. Oh, we have. Thank you, thank you, thank you. We have a very good evidence here from Galtoto. Another one here from Mr. Matito. And the other one the same thing. Thank you for this. I would like to read hypothyroidism and myxedema. So hypothyroidism results from the suboptimal levels of thyroid hormones. Types of hypothyroidism include primary, which refers to a dysfunction of the thyroid gland, more than 95% of cases. Central, due to failure of the pituitary gland, hypothalamus, or both. Then you have secondary or pituitary, which is due to entirely to a pituitary disorder, and hypothalamic or tertiary, due to a disorder of the hypothalamus, resulting in inadequate secretion of TSH from decreased stimulation by the thyrotropin releasing hormone TRH. Hypothyroidism occurs most often in older women. Its causes include autoimmune thyroiditis, that is Hashimoto's thyroiditis, most common types in adults. Therapy for hyperthyroidism, that is radioiodine surgery or antithyroid drugs. Radiation therapy for head and neck cancer, infiltrative diseases of the thyroid, amyloidosis, and scleroderma. Then have iodine deficiency and iodine excess. When thyroid deficiency is present at birth, the condition is known as cretinism. The term myxedema refers to the accumulation of mucopolysaccharides in subcutaneous and other interstitial tissue, and is often only to describe the extreme symptoms of hypothyroidism. Clinical manifestations, we have extreme fatigue, hair loss, brittle nails, dry skin, and number of tingling fingers, numbness, tingling of fingers, husky voice and hoarseness, menstrual disturbances, e.g., menorrhagia or amenorrhea, loss of libido. We have severe hypothyroidism, subnormal temperature and pulse rate, weight gain without corresponding increase in full intake, cachexia, thickened skin, thinning hair or alopecia, expressionless and mask-like facial features, sensation of cold in home environment, subdued emotional responses as the condition progresses, dull mental process and apathy, slurred speech, enlarged tongue, hands and feet, constipation, possibly deafness, advanced hypothyroidism, personality and cognitive changes, pleural effusion, ca- uh, pericardial effusion, and respiratory muscle weakness. There is that evidence yenye tunakuanga nayo huko kwa unit wise kwa ni ya endocrinology. I would like to have that evidence ya kutoka kwa ni ya endocrinology. Yeah, let me get that evidence. I think I have it here. Let me forward into the group this one. Have this one explaining the difference between both hypothyroidism and hyperthyroidism. I think with this one we can be able to understand it better. Two conditions that affect the thyroid gland. Thyroid function regulates metabolism and growth and development by producing T3, T4, that is the thyroid hormone, and calcitonin, which moves the calcium into the bone. Iodine is needed to create a thyroid hormones. Then we have already discussed about hypothyroidism, that is hyposecretion of the thyroid hormones, the T3 and T4, and with this we have an increased TSH. Causes, we have Hashimoto's immune-mediated low iodine, pituitary tumor, thyroidectomy. Symptoms, we have everything is low and slow. With this, I think we can be able to understand it better. Low, we have low temperature, low heart rate, low energy, lethargy, and fatigue. We have low hair, that is alopecia. Low libido, that is a sex drive. Slow GI motility, so we have constipation. Slow level of consciousness, so we have forgetfulness. Slow metabolism, we have weight gain. Slow menstruation, we have irregular missing periods. Then slow skin moisture, we have a dry skin. And for a complication, we have myxedema, then it's a medical emergency, which can lead to respiratory failure because of the low what low what yeah what yenye itakuwa low itafanya mtu akuwe na respiratory failure. Then severe deficiency to thyroid hormones, high risk after thyroidectomy, abrupt stop of levothyroxine. Symptoms, we have a hypothermia, bradycardia and hypotension. We have bradypnea, that is a reduction in the respiratory rate. We have severely altered level of consciousness, which can lead to coma. Priority, you maintain airway, intubation, setup at bedside. For the treatment, we have thyroid hormone replacement using levothyroxine, which leaves T3 and T4 in the body. Will be on medication forever. Take in the morning, that is 60 minutes before breakfast, at the same time every day. Then we have hyperthyroidism, that is the hypersecretion of the thyroid hormones. The T3 is high and also the T4. The TSH is low. Causes, we have Graves' disease. We have which is an autoimmune disease. We have too much uh, iodine intake, excess thyroid replacement, that is with the levothyroxine. We have a toxic nodule goiter, nodules on the thyroid stimulate T3 and T4. Symptoms, we have everything is high, high temperature, we have heat intolerance, high heart rate, tachycardia, dysrhythmia, high energy, we have interfastness and tremors, high excitability, we have irritable and difficulty concentrating, high metabolism, we have a weight loss, a high GI motility, you have diarrhea, high blood pressure, big bulging eyes and exophthalmos. Then you have bulging thyroid goiter and the hot, sweaty skin. Complication, you have the thyroid storm, medical emergency, large amount of the thyroid hormones releases at once, high risk after thyroidectomy. Symptoms, you have agitation and confusion, high fever, tachycardia, hypertension. Treatment, methimazole, corticosteroid to block the TNT for beta blockers. We have antipyretics. Treatment, methimazole and PTU, that is propanolol, block synthesis of the T3 and T4. Potassium iodide shrinks the thyroid before removal. Beta blockers for hypertension and tachycardia. Radioactive iodine uptake to destroy the thyroid. Then you have a thyroidectomy, which will require lifelong levothyroxine. So with that said, I think I can help people to give the cities. Let me have some cities. Let me have cities. Yes. Ama it's still not clear. It is still not clear. Yes. When you move, focus. We have something here from Winnie Win. Winnie Win. Hypothyroidism is a condition characterized by underproduction of thyroid hormones by the thyroid gland, leading to a slowdown of the body metabolism. Signs and symptoms: fatigue and sluggishness, increased sensitivity to cold, constipation, dry skin, weight gain, puffy face, hoarseness, and muscle weakness. Cause: hypothyroidism commonly results from Hashimoto's thyroiditis, an immune condition where the immune system attacks the thyroid gland, leading to reduced hormone production. Other causes include iodine deficiency, thyroid surgery, radiation therapy, and certain medications. We have diagnosis, TSH test, primary screening test for hypothyroidism. We have T4 test, measure the level of thyroid hormones. Treatment involves thyroid hormone replacement therapy to normalize the hormone. We have levothyroxine. Clinical features myxedema, severe hypothyroidism, then have goiter enlarged the thyroid gland as it tries to produce a more thyroid hormone. I think with this evidence from Win, I can get better cities. Yeah, yeah, yeah. Shaona cities ziko nishapewa hata swali ambalo linafuata. Ati moderator should not read. Nani huyu? Wasema moderator should not read hot. Sijaona hii. Why is that? Kwani nimepotea? Huh? Mi nimepotea. Moderator should not read everything. Mwambie polepole basi. Okay. Let me have the other question. Let me have the other question. Iko wapi? Oh, niliona. Thank you. So we go to question number 374. An elderly client has severe xeroxis. What topic should be included in your teaching plan? An elderly client has severe xeroxis. What topic should be included in your teaching? A. Maintain a warm environment. B. Take a hot bath every day. C. We have apply skin lotions after bath. D. We have use fabric softeners when laundering clothing. So let me have people tackling that question. Let me have Marwa. You know, the moment we repeat this thing in a stick more, hata kama ni kujirudia, also there is something yenye unapata haijajirudia. For example, hiyo ya win it had somewhere yenye inaonyesha hiyo mambo ya how the thyroid gland itakuwa enlarged even with the hypothyroidism, and that's what we needed to tackle the question. So let me have people tackling that question number 374. And as we tackle, I want you people to type what they understand by that the xerosis. Xerosis. Let me have people typing what they understand by xerosis. So people are endorsing C, from I am wise to Baha, yeah, and C reads apply skin lotions after a bath. So xerosis is the dryness of the skin. Okay, abdominal dry skin. Okay. So do you have an evidence, an evidence to support this? But even with logic thinking, applying skin lotions after bath will be the best, nene. So let me get some cities as also. Where is Galtoto? We need some evidence on the same cities. Some evidence. We have an evidence here from Joy. Thank you, Joy. Recommended tips for treatment of xerosis: minimize bathing to no more than once daily. Alternatively, bathe every other day and supplement with sponge baths of the axillary and anogenital regions. Avoid hot water. Use only mild soaps, that non-alkaline or oilated or super fetted soaps. Patch, do not rub the dry skin. Apply emollients, preferably plain petroleum, mineral oil, or lotions containing urea or alpha hydroxy acid twice daily, especially after bathing while the skin is still wet, to hydrate the strata corneum. Then blot oil that is applied to the skin with a towel to remove excess. What's the meaning of blot? This blot here, blot oil. So with that, I can get more cities. Let me get more cities. Yes, we are 106 in the chat. I expect more cities. So we have CTC from Beatrice all the way to who? To Kate, Sophie, to Milka. So let me have the other question. We have the other question. Thank you, Gal Toto. So the next question is question number 375. Which of the following clients should be most at risk for the development of type 2 diabetes? Which of the following clients will be most at risk for the development of type 2 diabetes? A. We have a middle-aged man who maintains normal weight. B. We have a young adult who is professionally a professional basketballer. And we have C, middle-aged woman who is the sole caretaker of her parents. We have D, woman over the age of 70 who is overweight and sedentary. So let me have people tackling question number 375. So 375 people are going with D, D from Chep. All the way me see we have Mercy, Toto, Maro, we have Ian, that dear mom, we have Rubikesh. Yeah. We have all the way Mercy to Milka. So we are endorsing choice D, and D states a woman over the age of 70 who is overweight and sedentary. Of course, this with D, the woman is has the risk factors, that is overweight and also having a sedentary life. Why is it not a middle-aged man who maintains a normal weight? Even if being a man is a risk factor, middle-aged man is a risk factor, he has no any other risk factor, so he is not most at risk. A young adult who is professional basketballer is not at most risk, and middle-aged woman who is the sole caretaker of her parents is not at most risk. So with that, let me have some cities. So this question was asking about asking about the risk factors of of DM. Uh, Thank you for this. Let me have another question. Thank you for your active participation. The next question is question number 376. A client received a liver transplant a day ago. If a client were to develop an acute transplant rejection episode, when should the nurse expect to see the manifestations? A. Approximately 4 days to 3 months later. B. Approximately 2 days later. C. Within the first 24 hours. D. Within the first 8 hours. Let me have people tackling question number 376. We have 376A from King. Let me have other people tackling that question. We have A from Priscilla, from Marion, from Missy, from Robbie, from Sharon. So people are endorsing A. I have not seen any contrary answer. Let me have more people tackling this question. Kellen also is going with A. So there's no any contrary answer. Okay, and A reads uh, approximately 4 days to 3 months later. So let me get an evidence. Let me have an evidence on this. She is evidence. She tupe evidence. Mwenye unauliza. Let me have some evidence. Where is girl Toto? Nipate evidence. Nipate evidence. Sharon, nipate evidence. I think I can have more attempts. We are very many in this chat. I don't expect such less. We are 115. So I expect more than the ones I'm seeing above. We have Joy also endorsing A, and Build endorsing A. So we are waiting for an evidence. Of any evidence. Evidence. Yes. As others are looking for evidences, others may be typing why they think A should be the answer, not the other. Yes. Let me have people typing why they think A is the answer, not the other answer. Yes. Nipate watu wanatype hapo waseme kwa nini ilianza na sio hii ingine. So you have an evidence here from Gracie as forwarded from T. So you have to read from what point from we can read from hyperacute rejection. Hyperacute rejection occurs minutes to hours after transplantation because the blood vessels are rapidly destroyed. It occurs because the person had pre-existing antibodies against the transplanted tissue or organ. There is no treatment for hyperacute rejection, and the transplanted organ is removed. Fortunately, hyperacute rejection is a rare event because the final cross matches before transplant usually determines whether the recipient is sensitized to any of the donor HLAs. Yeah, on occasion, for unclear reasons, the final
So wacha tuendelee. Hiyo acute rejection most commonly manifests in the first 6 months after transplantation. This type of rejection is usually mediated by the recipient's lymphocytes, which have been activated against the donated foreign tissues or organ. In addition to the cell-mediated rejection, another type of acute rejection occurs when the recipient develops antibodies to the transplanted organ. It is not uncommon to have at least one rejection episode, especially with organs from deceased donors. These episodes are usually reversible with additional immunosuppressive therapy, which may include increased corticosteroid doses or polyclonal or monoclonal antibodies. Unfortunately, immunosuppressants increase the risk for infection. To combat acute rejection, all patients with transplants require long-term use of immunosuppressants, putting them at a high risk for infection, especially in the first few months after transplant when the immunosuppressive doses are highest. Chronic rejection. Chronic rejection is a process that occurs over months or years and is irreversible. Chronic rejection can occur for unknown reasons or from repeated episodes of acute rejection. The transplanted organ is infiltrated with large numbers of T and B cells, characteristic of an ongoing low by loss of bile ducts in kidney transplants. Hizo zingine hapo sioni. So ndo hizo evidences tumetumiwa, tulikuwa number 376. Naulizwa, a client received a liver transplant a day ago. If the client were to develop an acute transplant rejection episodes, when should the nurse expect to see the manifestation? So from your evidence, tunasiti na nini? The self-mute hizi. Tunasiti na nini? Kuna pia evidences zingine hapo. Kuna hiyo evidence tumetumiwa na Regi ya acute, chronic, time yenye huwa zina develop, hyperacute, all of them. So from hizo evidences tunasiti na nini? Charles, siti. Tumieni the next question. Tumieni the next question. Juu yangu ina voice cancellation, so itashinda ikinisumbua. Sawa. So number 377. Miss Smith complains of nausea and vomiting following her daily chemotherapy. Miss Smith complains of nausea and vomiting following her daily chemotherapy treatment. The most appropriate nursing intervention will be to A, keep NPO until her daily chemotherapy is completed. B, provide antiemetic medication 30 to 40 minutes prior to each treatment. C, provide clear liquids until the chemotherapy is completed. And D, schedule chemotherapy administration to bedtime. So to attempt number 377.
Wewe unmute usikize nini?
Nini hiyo? Leave out. Enda uchukue tutaenda. So people are endorsing B number. Thank you Mungaji. So people are endorsing B. Nani wameanza hizi mambo? Hebu huyu atolee shit hii kitu hatukuambia. Mtu wa delete hiyo kitu iko hapo. Huyo hadi usidelete pekee, udelete na unblock. So people are endorsing B and B states, what is this question? B states provide antiemetic medication 30 to 40 minutes prior to each treatment. So hata sikuajua swali ni gani. At the MS Smith complains of nausea and vomiting following her daily chemotherapy treatment. The most appropriate nursing intervention would be A. Keep and pure until her daily chemotherapy is completed. B. Provide antiemetic medication that is 40 minutes prior to each treatment. C. We have provide clear liquids until the chemotherapy is completed. And D. You have schedule chemotherapy administration to bedtime. And people are going with B. B states B states provide antiemetic medication 30 to 40 minutes prior to each treatment. So is there some evidence? Rudikisha naweza timunga na Big Mario mko pamoja. Mnaendelea reboot ya kwenda wapi? Wewe wacha mambo mingi. Rudikisha wacha mambo mingi wewe. Mambo ya reboot I'm asking someone else. Focus Rudikisha. What are the phases of chemotherapy? Mbona nani anauliza? Thank you happiness. Umeblock huyo mtu vibaya sana. Then beaches na sasa hizo antiemetics zitakuwa long term use now. I am Moise is saying the phases we have induction, consolidation, maintenance. Acha nipate some evidence about hii mambo. We have Chero ametupea something here. Understanding chemotherapy stages. Chemotherapy usually lasts 3 to 6 months depending on the cancer type, the stage and the patient response. Chemotherapy is administered in different phases. We have induction phase, consolidation, and maintenance. For the induction, is the first and most intensive phase. Induction aims to destroy the majority of cancer cells. It usually lasts about 1 month and helps achieve remission. Consolidation phase follows remission to eliminate remaining cancer cells using the low dose chemotherapy. This phase can last for several months. Then we have maintenance phase, involves low dose chemo over an extended period to prevent recurrence. It may continue for many months depending on the type of cancer stage. Thank you. Is there no any evidence to show what should be done during your time ya kufanya hiyo chemotherapy? It would be better if we read yeah, it would be better if nipate some evidence to show how that chemotherapy should be done. Yes, so as we can support our answer better. I'm waiting. Naongoja evidence. Galitoa shatuma maswali. CTA. Ngoja kidogo. Kwani niko wapi mimi? My God. At time najipata niko na huku juu nasoma vitu hata zilikuwa zikisoma. So let's continue. Natafuta evidence ingine. Mtu atume evidence ingine. Yes. Nimeona happiness kwa chat na sioni evidences. What's not going on? Happiness. Ama uko hapo tu wewe leo umesema leo kazi ni kublock watu. They're not giving the evidence. I need an evidence. Yes, an evidence. Yeah, we have an evidence from Sharon here. Thank you, Sharon. Chemotherapy, a powerful cancer treatment using medicines to destroy fast-growing cancers. Curative treatment remove cancer. Neoadjuvant before surgery to shrink tumors. And the types we have also, these are the types. We have curative neoadjuvant. We have adjuvant, that is after surgery to kill remaining cells. We have palliative to control the symptoms. Mm, side effects and hot health. The rest, short walks, small meals, gentle scalp care, sun protection, anti-nausea medicine, fluids, soft food, small frequent meals, hand hygiene, avoid crowds, prevent cuts and injuries, notes, reminders and rest. We have side effects, we have fatigue, hair loss, nausea and vomiting, loss of appetite, low immunity, easy breathing, and chemo brain. Yeah. Then you have some cities. Evidence yenye nataka sipati, labda nipate cities, but at least this is evidence natuonyesha hapa give anti-nausea medicines and some food. So let me get some cities. I would like to know whether hii mambo yenye amesema on the questions mambo ya NPO kama it should be there. This for these other choices. Hii keep the patient NPO. This one for providing clear liquids until the chemotherapy is completed. Hii ingine schedule chemotherapy administration to bedtime. I would like to know. Unfortunately, the mother of evidences, happiness, has decided to only block people and not provide evidence. It's normal. So we have the next question here from Gal Toto. Yes, we have question number uh, 388. Is it 388? No, question number 378. The nurse in charge identifies a patient responses to actual or potential health problems, during which step of the nursing process the nurse in charge identifies a patient's responses to actual or potential health problems, during which step of nursing process. A, we have assessment. B, we have diagnosis. C, we have planning. And D, we have evaluating. Let me have people tackling question number 378. Yes, 378. Let me have people tackling question number 378. Ruth is endorsing B. Cheryl's championing for C. JC championing for D. Have King championing for B. Ruby B. Ruby Cash B. Ruby D. Dopa D. Mercy D. Summer D. D. So people are championing for D mostly. Wengi ni D. Then you have some people with B and some people with C. D states evaluating. B states diagnosis and C states planning. According to the question we have been asked, the nurse in charge identifies a patient's response to actual or potential health problem during which step of nursing process. This question is designed in a way iweze kutuchanganya kidogo, but I think we can meditate more about this question. Yes, it asks. The nurse in charge identifies a patient's response, so response for a patient, to actual or potential health problem. So diagnose this patient with, hapa amesema response to actual or problem during which step of nursing process. Why have not people not taken the assessment? Kwani watu hawajachukua or we have someone going with A, with A. So uh, nurse in charge identifies a patient's response to actual or potential health problem during which step of nursing process. Response to actual or potential. Is it will it Will it be assessment? But I'm not sure. You know, the 78B huyu anakataa anasema B. Oh, Paul anasema identifying a patient actual or potential health problem is diagnosis. Now the question is says patient response after now diagnosis, which is evaluation. That is Paul. Okay, thank you, Paul. Let's also make it tumetumiwa hapa na dopa. Assessment, collect complete patient data, subjective and objective for the nurse observed. Okay, nursing diagnosis, identify actual potential health problem using the NANDA. We are planning this month both set smart goals and expected outcomes tailored to the patient's needs. When we have implementation, carry out nursing intervention, independent and collaborative. We have evaluation, we review patient response and determine whether the goals are achieved, modify the plan if needed. The nursing process ensures systematic care, better decision making, and improve patient outcomes. So with that, I can get some cities. Let me get some cities. Yeah. CTD. It cannot be assessment, and it cannot also be planning. Yeah. So CTD. Let me have the other question. Oh, kuna mtu amesema CTB. Nani huyo? CTB. I am Moise. Kwa nini unasema CTB? You have question number 379. Which of the following clients is a greater risk for burn shock? Which of the following clients is a greater risk for burn shock? A. One with 90% superficial burns from a turning bed. B. One with 10% TBSA from a gasoline explosion. C. One with radiation burns following treatment for cancer. Then D. One with greater than 50% TBSA from a high voltage electric accident. So let me have people tackling question number 379. Na kuna mtu ameunmute eh? Mtu ameunmute, unmute mic yake. So people are endorsing both A and D. We have Cheroe, Del D, Ronnie going with A, have Flora D, Moise is going with A. So people are championing for both A and D. And A is one with 90% superficial burns from a turning bed. Then we have D, one with greater than 50% of TBSA from a high voltage electric accident. So what does it mean by a turning bed? What does it mean by a turning bed? Yeah. Let me get people typing what it means by a turning bed. So people endorsing both D and A, one with 90% factual burns from a turning bed. D, one with greater than 50% TBSA from a high voltage electric. Kwani diamam ni male ama nimesikia sana? Diamam ni male. Ni mo. So naona watu hawaandiki vitu nataka kuona wakiandika. Hiyo turning bed ni nini? Yeah? What is turning beds? Ile bed inakuanga kando ya pool. Oh. OJ Brian wants to explain something. Eh? You can unmute.
Okay, I hope I'm audible enough. For this question 379, I'm going with D because one with more than 50% total burnt surface area from high voltage electric current accident. Burn shock is a complex combined hypovolemic and cellular shock. And we must understand that a total body surface area burn that is greater than 50% triggers a massive systematic inflammatory response. And this causes widespread capillary permeability, or what we'll call capillary leak syndrome. And rapid fluid shifts from the intravascular space into the interstitial tissues might occur. Now, furthermore, high voltage electric injuries cause extensive and unseen deep muscle damages, things like rhabdomyolysis, you see. So this releases myoglobin from blood, which can precipitate acute kidney injury. So exponentially, we are having a situation whereby we are increasing the patient's fluid resuscitation needs and risk for shock. So turning bed burns, these are superficial first-degree burns that only affect the epidermis. The skin barrier remains intact and the capillaries are undamaged, preventing massive fluid shifts that can cause burn shock. For 10% total body surface area burns, like in answer B, we have, while that can be serious, it's relatively small. The systemic inflammatory response is localized and it's manageable. For radiation burns, like in C, these are therapeutic radiation burns that are localized and develop gradually over weeks, you see. So allowing the body to maintain hemodynamic hemostasis is of essence. So we must make sure that we think about fluid resuscitation, whether it's by crystalloids of Rinker's lactate, based on a calculation of the body surface area by Parkland's formula. So this is a patient you want to give, because of 50%, this is a patient when you calculate using the Parkland's formula, you want to give them close to, I think, 11,200 milliliters of fluid. For the first 8 hours, you infuse half the amount of fluids that is calculated for the 24 hours. Because in the 8-hour window, the time for the time of the burn injury, not of the time of the arrival at the hospital. And then the remaining 16 hours, you infuse the remaining 50% of the fluid, you see. So such a patient, let's take, for example, if they were 70 kg as an adult with 40% total body surface area with partial thickness burns, a total of 24-hour volume is supposed to give them 11,1200 mils as per calculation. So the first 8 hours, you give them 5,600. For the next 16 hours, you give them 5,600. That is 350 mils per hour, you see. And then you must also be careful about the essential resuscitation principles, because fluid of choice is lactated drinkers, and delayed arrival of the patient at the facility. If they are 2 hours late after the burn occurred, the first half of the fluid must be infused over the remaining 6 hours of the initial 8-hour post-injury window. And the monitoring efficacy, you must adjust infusion rates based on hourly urine output. For adults, 0.5 to 1 mil per kg per hour. For electric injuries, as the one we are looking at, you maintain 1 to 2 mils per kg per hour to actively flush myoglobin out of the renal tubules. Otherwise, we are going to have a patient who is going to end up with AKI. Okay? So back to you, moderator.
Wow. Thank you, Brian. Let's appreciate him. I think we have understood it in a better way from the consultant himself, OJ Brian. So with that explanation, I think we can have some cities. Let me have some cities. Yeah. Let me have some cities. And the other question. Hey, people outside here are gonna content. Hey, no man. So Yeah, let me have the other question. Who are sitting with the D? Another question. Thank you, girl Toto. Uh, the next question is question number 380. Which one of the following topics should be included in a health message on burn prevention? A. Which one of the following topics should be included to a health message on burn prevention? A. We have use a solar power light. B. We have check smoke detectors annually. C. We have do not use oven for cooking. D. We have set water heater no longer than 48 degrees Celsius. Let me help people tackling question number one. Number 380. Yes, let me help people tackling question number 380. 380 people going with B from I am wise. I am wise. You have Dell, Sony, Yami, Masi, Dopa, Bahar. Tony, you have Karenia, OJ, Masi, Florashi, Miriam, Chero, Mariam K. So people are endorsing B. Abi Asha City Adi. So and B reads check smoke detectors annually. Uh, yeah. So let me have some cities. I think the answers are not that relevant. Let me have some cities. So no, we have Mercy. Mercy is going with the D. And Smiley also. Before you even continue, Smiley and Mercy are going with the D. Also, Miss Boarie is going with the D. Why do you think D can be the answer? Miss Boarie, maybe you can tell us why you think the D can be D can be an answer. Set water heater no longer than 48 degrees Celsius. So should we have an evidence? Ama tupe akina nani waje explain Miss Boarie. Yes. Okay, OJ Bryan, setting home water heaters to a maximum of 48 degrees Celsius is a critical burn prevention strategy. At this temperature, it takes several minutes of continuous exposure to cause a deep burn, whereas water heated to 60 degrees Celsius can cause a third-degree burn in just 2 seconds. That's why I am going with the D. That is OJ Bryan. No man. So why not B? OJ, why not B? Why not smoke detectors? And we are answering the question, which one of the following topics should be included in a health message on burn prevention? So I need an evidence. Let me get an evidence. Win anasema smoke detectors, Kadot anasema B is for fire prevention. Oh, Tebu, where is it? Mhm. B is for fire prevention, but fire is bado inaweza cause. Na stima bado inaweza cause. So should we tuachane na B? B is for preventing fire. Okay. So let me have some evidence. B is for preventing fire. Let me have some evidence. Some evidence, please. People are supporting the consultant himself, OJ Bryan. That is going with D, and you also have some people going with B. Mi naweza tu ongea. OJ Bryan. Sawa. Unmute.
Okay, I hope I'm audible enough. You see, the reason as to why I'm going with D is that when you set heat water no longer than 48 degrees centigrade, as often recommended 49 degrees Celsius or 120 degrees Fahrenheit in other countries. You see, this prevents scalds. So a scald is a burn from hot liquid or steam. And this is actually normally used by most people in relationships to end up killing their spouses. So setting the heater to this limit stops the water from getting too hot. You see, at 48 degrees Celsius, it doesn't become too hot. It gives you time to react before a bad burn happens. As opposed to these other options like air, you see, solar night lights do not stop burns. They only help you to see in the dark to prevent trips. And smoke detectors must be checked every month, not just once a year, as opposed to the water heater that is set at 48 degrees Celsius or centigrade. You can also you can also you can use ovens safely because some of them have thermostats. You just need to wear oven mitts and or mitts tunaziita aje huku kwetu, tunaziita vitambaa, and you follow cooking safety rules, you see. So for me, setting water heater at no longer than 48 degrees Celsius is the most recommended way to prevent scalds formation in the event that somebody gets burnt. Unless somebody has a different opinion, let them also give their views.
Okay, thank you, Consultant OJ, for the good explanation. Yeah, hope we have understood it better. Big dopamine is saying, would you have prevented the burn or lessened the effect of potential burn? Mercy, smoke detector should be checked monthly, not annually. That is from Mercy. Okay. So we have eliminated B. Yeah? So do we all agree? Do we all agree with the D? If you all agree, I can get some cities. So Beatrice is asking about converting degrees to Fahrenheit. Maybe we can explain to her or give a formula on how to do it. We have a very good linear from Chero evidence, burn prevention, protect your child from scalds and burns. We have lower your hot water temperature to 49 degrees Celsius, that is 120 Fahrenheit. Keep hot drinks away from the child and make sure your child is safe in the kitchen. Stay with your child during birth time. Okay. So let me get more cities. More cities. Let me get more cities. CTD Paul is saying smoke can also cause inhalation burns, but chenye inatoa hiyo ni checking detectors annually. It should be checked monthly. Okay. Thank you, Paul. Yeah. Thank you. Uh-huh. Let me have the other question. Thank you, Gal Toto. The other question is question number 381. While providing care to an old woman with a cast on her lower arm from below the elbow to above the fingers, you perform a neurovascular assessment. What's the possible complication while providing care to an old woman with cast on her lower arm into bracket from below the elbow to above the fingers? You perform a neurovascular assessment. What is the possible complication? A. We have slightly edematous fingers. B. We have warm pink skin above the cast. C. We have pale cold fingers. And D. We have pain rating of 2 on a scale of 1 to 10. Let me have people tackling question number 381. Yes. Let me have people tackling that question number 381. Have Chero going with C. Paul C. Rubiola C. Have Smiley. Peter Kingston. Kate Brown, Onyango, Mishi, Treasure, Flora, Charlie. So people are endorsing choice C. And C states Question number 381. C states pale, cold fingers. Why not the other one? Why not slightly dematous fingers? Why not warm pink skin above the cast? Why not pain rating of 2 to a scale of 1 to 10? But we have asked about a complication, the possible complication. And remember, if a cast is applied, it will apply some pressure on that part that it has been applied. So that pressure can impair adequate supply of uh, blood, and this may lead to the cold fingers and also the paleness. Yes. So if it's not applied well, it can compress knee further and cause paleness and knee. Then you have let's read this evidence from the mother of evidence, happiness herself. We have compartment syndrome symptoms. Have remember the 6 P's. We have pain, pala. Pain commonly felt with passive stretch, that's the early sign. Pala, paleness of extremity. P for paresthesia, tingling or burning sensation. P for paralysis, inability to move the limb. Then we have poikilothermia, that is cold to touch. Then we have pulselessness, no peripheral pulse. This is the late sign. Remember, a compartment syndrome is similar to what is happening after we apply this cast. That pressure that is exerted, and then after exertion of the pressure, the fluid may shift from the compartment syndrome. It may shift, causing the compartment syndrome. Yeah. So what is the cast? Dopa ni yeye anauliza. Someone to explain. Uh, So let me have some cities. Let me have some cities. So let me have the other question. Cities. Okay. The other question. Thank you, guys. We have question number 382. Uh, a patient becomes restless and tells you she has a headache and feels nauseous during hemodialysis. Which complication do you suspect? A patient becomes restless and tells you she has a headache and feels nauseous during hemodialysis. Which complications do you suspect? A. We have infection. B. We have disequilibrium syndrome. C. We have air embolism. And D. We have acute hemolysis. Let me have people tackling question number 82. Dada anasema your voice is fading. Okay, let me work on it. A patient become restless as you. Let me have people tackling question number 82. So people are championing for both B and D. No any other contrary answer. And we have an evidence loading here from mother of evidences, happiness herself. Dialysis complications. We have quick management guides, early recognition, prompt action, better outcomes. We have hypotension. Signs and symptoms, we have low blood pressure, dizziness, nausea, weakness. We have muscle cramps, signs and symptoms, we have painful cramps, legs or abdomen. Okay, sorry, I've not read the management. For the management of hypotension, you should stop or reduce the ultra-filtration of the urine. ultrafiltration rate. You place the patient in trundle back position. What do we mean by trundle back position? Kichwa ikiwa chini, miguu ikiwa juu, trundle back. Then you have IV normal saline 100 to 200 ml bolus. Monitor BP closely. Prevention: acute dry weight, slow rate of fluid removal. Avoid meals during dialysis. Use cool dialysis. Then you have muscle cramps, signs and symptoms. You have painful cramps in legs or abdomen. Management: reduce ultrafiltration. Give a normal saline for hypertonic saline, gentle stretching and massage. Prevention: avoid aggressive fluid removal, sodium profiling, have an adequate dialysate sodium. We have disequilibrium syndrome (BDS). Signs and symptoms: we have headache, nausea, vomiting, restlessness, confusion, and seizures. That is when it goes to severe. Management with slow or stop dialysis, IV mannitol, supportive care, monitor neurologic status. Prevention: start with uh, low blood flow rate. You have short initial sessions, then gradual increase in dialysis dose. Then hypertension as a symptoms, we have high blood pressure, headache, restlessness, dull vision. Management should adjust the dry weight, optimize fluid removal, antihypertensive medication, monitor BP. Prevention: proper fluid and sodium control, correct the dry weight, and regular BP monitoring. We have infection. For infection, access-related signs and symptoms, we have fever, chills, redness, swelling, and past discharge. Management to take blood culture, start heavy antibiotics, remove infection catheter, infected catheter if required, local care. Prevention: strict aseptic technique, proper catheter care, regular access monitoring, and staff training. Have embolism, sudden breathlessness, chest pain, anxiety, loss of consciousness. Management: we should clamp lines immediately. Left lateral trended back position, administer oxygen, monitor vital signs. Have hemolysis, that is back pain, dark reddish blood in tubing, restlessness, and nausea. Management: you stop dialysis immediately. Do not return blood. Check blood lines, dialyzer, supportive care. Prevent kink. That is by for prevention. You prevent kink in blood lines. Check dialysis temperature. Avoid chemical contamination. Regular machine maintenance. For the allergic reaction as a complication, dialyzer reaction, signs and symptoms, you have itching, rash, chest tightness, breathlessness, and anaphylaxis, which is rare. Management is to stop dialysis, give antihistamines, give steroids, oxygen support, monitor closely. For prevention, use a bio, biocompatible dialyzer. Observe during first 15 to 30 minutes pre-medication in the high-risk patients. So monitoring protocol, blood pressure every 30 minutes, pulse every 30 minutes, SpO2 as needed for the critical patient, machine alarms, continuous monitoring, then hiyo access ya kuweka before, during and after dialysis. Then emergency tray must be ready, that's the oxygen, normal saline, and also adrenaline 1 mg per deciliter. We also have hydrocortisone, antihistamine, and suction apparatus. In case of emergency, call for help. Prevention tips: maintain correct dry weight, avoid high ultrafiltration rate, ensure adequate dialysate composition, strict aseptic technique, regular machine maintenance, educate patient fluid diet, meds, record and review complications. So with that, I can get CTs. Let me get CTs. So watu wana CTB, CTB, CTB. Okay, thank you. So let me have the other question. Uh, Thank you, Galdoto. The next question is question number 383. A patient, Kante, 16 years old, is brought to the emergency department with history of sodium hypochlorite or jig spill on the left eye 5 minutes ago. The first most appropriate nurse action will be a patient candidate 16 years old is brought to the emergency department with history of sodium hypochlorite, jig, that is jig, spill on the left eye 5 minutes ago. The first most appropriate nurse action will be A. Immediately refer to ophthalmologist for review. B. Administer topical antibiotic and analgesic. C. Test for visual acuity to check extent of damage. D. Patch the eye after irrigation with clean water. Let me have people tackling that question. Question number 83. People are endorsing B from Mama's Girl all the way to Robbie. And these states, what is this? These states patch the eye after irrigation with clean water. So why not A? Why not B? Why not C? Why why do we need to test? So testing visual acuity is not most appropriate at the moment, and that's something that should be done by the ophthalmologist. So OJ Brand has an input. You can unmute and dispense knowledge. OJ.
Okay, thank you. I hope I'm not too much. In as much as we want to patch the eye after irrigation with clean water, you must immediately and for a prolonged time irrigate the eye as a first and most critical action. Because when you are irrigating the eye, you stop damage, because sodium hypochlorite, that bleach that was spilled into the eye, is a strong alkaline chemical and it causes tissue death. So flushing the eye washing the eyes removes that chemical and balances the pH of the eyes. And the timeline should be within 10 minutes, with a duration of flushing with water for 15 to 30 minutes. The reason as to why A, B, and C are wrong is because you must irrigate the eye first. Delaying irrigation to test vision or prescribe medication or call a specialist allows the chemical to cause permanent eye blindness. So to protect the unaffected eye, you must use proper positioning of fluid control. You tilt the patient's head toward the injured side. You run water from the inner corner, nasal side, to the outer corner. And then you protect the healthy eye by positioning. You see, this positioning prevents the contaminated water from draining across the nose into the uninjured eye. Now you keep the lids open. Hold the eyelids with your fingers while you are irrigating with water. And you also instruct the patient to look up and down and sideways during the wash. And as you do that, flush continuously for 15 to 30 minutes using normal saline or clean water. Now, thereafter, you have to check the pH. Stop only when the eye's pH returns to 7.0 to 7.3, if I can remember. Testing it with litmus paper if available. Okay, because some of the signs of chemical burns in the eyes, this bleach penetrates the eye deeply and they can cause rapid damage. Some of the damages that you will mostly discover as things like blanched conjunctiva. When the conjunctiva is blanched, the white part of the eye looks pale or marble white due to destroyed blood vessels. Or this child can even have corneal opacification. The clear window of the eye becomes cloudy, hazy, or even completely white. That is the seriousness of bleaches in children's eyes. They might have severe pain during this because of extreme burns, and the nerves are destroyed and there is numbness. And the child might have inability to open the eyes. severe involuntary blinking, something we call blepharospasm, and the eyes might swell, and that might include the eyelids. So sudden drastic drop in visual acuity may also occur. So apply direct pressure. As a nurse, you see when this patient is brought to you in casualty, apply direct pressure firmly on the wound using a clean cloth or a sterile gauze. And then you elevate, you raise the injured limb above the level if possible. Because these are also other common emergencies that occur when a child is having bleach in the eyes. Okay, so I think you repeat these ones alternately every 5 minutes. Okay, that is all I had to say. I hope it helps somehow. Thank you.
Thank you, OJ Brian, consultant himself. Let me have people appreciating him. Kuna mtu anasema utaweka litmus paper kwa macho ndo ujue pH. So OJ, you can type and respond to him. Unasema huyu ni AI sasa. You people have content here outside. Pumpkin anasema shajinyakulia huyo. Okay. Thank you, OJ, for that great explanation. I think with that explanation, and also you have a very good evidence here also from Sharon. Chemical injury of the eye, types of chemicals involved, alkali agents or acids, ammonia, lime and bleach, acid, we have sulfuric acid, hydrochloric and acetic. We have where alkali is more dangerous, penetrates deeper into the ocular tissues and causes a liquefactive necrosis. Symptoms, we have severe pain, redness of the eye, tearing, inability to open eyes, blood vision, foreign body sensation, photophobia, light lens, light sense, your light sana. So emergency first aid, we have immediate irrigation is critical at least 30 minutes. Avert the leads, remove the trapped particles, do not delay irrigation. Thank you for that, Sharon. So I got cities. I need more cities, more cities. Winnie Win is saying foreign objects. Do we start removing the foreign body? I think we can remove the foreign body by irrigation. So let me get more cities and the question, the next question. Thank you, Rubikesh, for updating the scholarship. Thank you, Dr. for the questions. And the next question is question number 384. A classification of ringworm that infects the fingernails is Tinea corporis, Tinea ungunium, Tinea cruris, and Tinea pendis. Let me have people tackling question number 384. So people are championing for B. Let me have that evidence. Ile evidence fulani tunakuanga nayo I need that evidence. Yes, ile evidence yenye tunakuanga nayo huko kwa yes, kuna ile evidence fulani yenye it has listed all of them. Let me get that evidence as I get future row for this. Tinea corporis is for body, capitis is for skull. Then you have Tinea pendis for athlete's foot, Tinea cruris for groin, Tinea ungunium for nails. Thank you. I have another one here forwarded from Brenda by Happiness. Tinea ungunium nail, Tinea capitis skull, Tinea pendis foot, Tinea corporis body, Tinea cruris inguined. OJ Brown is saying Tinea ungunium, the onychomycosis, a fungal infection of the fingernails or toenails, makes the nails thick, brittle, and discolored. Have Tinea corporis, ringworm of the body skin, like arms, legs, trunk, causes red ring-shaped rashes. Tinea cruris, ringworm of the groin, also known as jock, each teniapedes of the foot, also known as athlete's foot. So Masi saying hiyo yote iko kwa kichwa. Paul mwenye hii DP chunga next time itakuwa mkono tu pekee. Nada. So let's have some cities. OJ Brian, very intelligent man. But I believe knowledge is not congenital. So either way, if someone is intelligent and well knowledgeable, I believe he or she has taken time to accumulate that content, that knowledge, and that intelligence, despite maybe a person having a high IQ. OJ amesema acheni bana, ni insomnia. So let me have the other question. The other question, thank you, Gal Toto and Rubikesh. The other question is question number 385. Following gastrectomy, dumping syndrome occurs as a result of following gastrectomy, dumping syndrome occurs as a result of A. Have reduced gastric motility resulting from vagus nerve stimulation. B. Removal of acid producing cells, thus resulting in reduced absorption of vitamin B12. Say we have rapid gastric emptying of the osmolar fluid and substances into the duodenum. D. We have damage of the vagus nerve and the cardiac sphincter. Let me help people tackle that question number 385. Let me help people tackle question number 385, and people are going with a C from Ruby, Sharon, all the way to Joyce, Abud. So people are going with C, and C states rapid gastric emptying of hyperosmolar fluid and substances into the duodenum. So we have a good evidence here from Happiness, mother of evidence. So dumping syndrome is an unpleasant set of vasomotor and GI symptoms sometimes occur in patients who have had gastric surgery or a form of vagotomy. It may be the mechanical result of surgery in which a small gastric remnant is connected to the jejunum through a large opening. Foods high in carbohydrate and electrolytes must be diluted in the jejunum before absorption can take place, but the passage of the food from the stomach remnant into the jejunum is too rapid to allow this to happen. The hypertonic intestinal content draw extracellular fluid from the circulating blood volume to the jejunum to dilute the high concentration of electrolytes and sugars. The ingestion uh, so the patient can eat fat and so with that evidence, uh, let me get some cities. Some cities. So let me give the next question. Na hizo zingine Ojebran anauliza why not the others, why are the others not answers? Question number 385. Why not reduce GI motility resulting from vagus nerve stimulation? Then we have why not removal of acid producing? But we are asking about the dumping syndrome. Na hiyo yenye kwa dumping syndrome tumeona from the evidence that has been presented here by Happiness herself, tumeona a unpleasant set of vasomotor and GI symptoms by patient who have had a surgery of vagotomy, maybe mechanical result of surgery in which a small gastric remnant Hii network iko na ujinga. Connect the jejunum through a large opening. Food high carbohydrates and nutrients must be diluted in the jejunum before absorption can take place. The passage of food from the stomach remnant into the jejunum is too rapid. Allow this to happen. Hypertonic and sustainable contents through extracellular fluid from the circulating blood volume, the jejunum to produce the high concentration of electrons and sugar. Maybe OJ, you can unmute and say something. This person knows inject.
Thank you. I hope I'm not being too much. Yeah, we are correct to say that rapid gastric emptying of hyposmolar fluid and substances into the duodenum is the correct answer. And it simply means that that dumping syndrome happens when the stomach empties too fast, as you always know. But after gastrectomy, surgery to remove all or part of the stomach loses its natural ability to hold food, more of like the reservoir, and control how it lives. So food is dumped quickly into the small intestines, and this food is highly concentrated. It's hyperosmolar. Highly concentrated food is hyperosmolar. So the high concentration tends to pull large amounts of water from the blood into the intestines. Now, when that happens, there's a cause of a sudden drop in the blood pressure and bowel swelling. That is why they have this distension. For vagotomy affects normal emptying, but it usually causes rapid emptying, not just reduced motility. Remember, it causes rapid emptying, but reduced motility. For answer B, while removing acid-producing cells, they're called parietal cells. While removing the parietal cells, this causes vitamin B12 deficiency. So it lowers the intrinsic factor. So by the deficiency of vitamin B12, intrinsic factor is lowered, and this one is one of the reasons as to why people contract anemia. So not dumping syndrome. Okay. For answer D, the cardiac sphincters, they connect to the esophagus, and damage to it causes issues like acid reflux, not dumping syndrome. So I would appreciate if, in as much as we get the right answer, but we also get to know what do these others mean. And I think those who always gain much from my presentations are those who are always awake in the morning. So jaribu. Thanks for giving me the opportunity. Back to you.
Let us appreciate OJ Brand for the good work. I think we have tumeelewa better. Thank you, OJ Brand, for that. I think with that explanation, we are also very motivated to kudimia content. Yeah, thank you. OJ Brand anasema yeye ni sister. Okay, thank you. So let me have the other question. Iko juu sana. Let me have the other question. Let me have the other question. We should read to kuwe na content, because we need more people like OJ Brand to make sure that the discussion is very effective. Yeah. So the next question, Winnie anasema niongeze sauti. Okay. Yeye ana strain. Maybe it's your gadget. Sorry to say. We have question number 386. The intracranial hemorrhage with the worst prognosis is A. We have cephalohematoma, B. Epidural hemorrhage, C. We have intracerebral hemorrhage, then we have D. Subarachnoid hemorrhage. So let me have people tackling question number 386. The intracranial hemorrhage with the worst prognosis. Let me have people tackling that question. Jero is going with C. We have Fauzi. Quinta is going with C. Beola C. Yeah, Justus. We have Mishi. So people are championing for C. You have Mercy C. Beatrice, Marion K. C. Endorphin. So people are championing for C. OJ Brown have C. And C states. C states. Where is it? The intracerebral hemorrhage. So why not the other ones? Why not cephalohematoma? Why not epidural hemorrhage? Why not subarachnoid hemorrhage? Yes. Why not the other ones? Let me have people typing. Okay, OJ Brand, I can explain. I'm being no OJ Brand, you're not being too much. We are here for knowledge, and we really appreciate for yeah. So you can continue.
Okay, for 386, we can go with intracerebral hemorrhage because it's a bleeding that occurs when within the space of the brain parenchyma, and it's often associated with significant physiological impact because it has direct tissue injury and rapid increase in intracranial pressure. So these two factors will always contribute to high mortality rates, and they can lead to a potential for long-term functional impairment compared to the intracranial bleeds. bleeds. Now, for intracerebral hemorrhage, which is also the worst prognosis, that bleeding is located deep within the brain tissue. This can lead to secondary damage from edema and possibly localized pressure on vital structures. You must understand that those brain structures that are situated below the larger part of the brain, like the pons. I think Morphine tried to explain this yesterday morning. The subarachnoid hemorrhage, just because the brain contains three things, it's just the skull and it cannot expand. It contains the brain that is not supposed to expand and CSF. So it will find space by damaging other brain organs or by creating CSF leak. Okay, so for subarachnoid hemorrhage, that bleeding in the space between the brain and the arachnoid membrane is often presenting with what we call thunderclap. By thunderclap headache, a thunderclap headache, more of like unasikia ni kama kichwa imekuwa na some sort of, you know how thunder behaves, and then macho inapata sort of like a flash. So that is what we call thunderclap headache, and it carries the risk of significant morbidity and complications. And for epidural hemorrhage, this one is never quite serious, but then it involves bleeding between the skull and the dura mater. So it is in most cases huwa inakuwa associated na trauma to the skull fractures. Na in as much as inakuanga serious, it typically has more favorable prognosis. That is kama itakuwa identified early and managed with surgical decompression. For cephalohematoma, that is where you have a collection of blood between the newborn scalp and the skull bone. And because it's extracranial outside the skull, it does not involve the brain and generally resolves by itself without serious complications in like a few days, okay? A few days to weeks. So that's why we, as a nurse, you'll really need to put into practice the use of a Glasgow Coma Scale, which is a standardized tool to measure that person's level of consciousness after a brain injury. So for those who have a minimum of 3, they get into deep coma or death. Those who have a maximum of 15, they are fully awake and alert, but they cannot do it. They are in cabbage state because we know that the GCS should be between 5 and 15. And I hope you remember how the GCS is done: eye-opening, verbal response, motor response, and the classification is that healthcare professionals added 3 scores together to classify the severity of brain damage. If you have a Glasgow Coma Scale of 13 to 15, that is mild injury. It could be manageable. If you have between 9 and 12, that's moderate. Okay. But if you have 8 or less, that is severe injury, and it's mostly in patients with coma. Okay. Yeah, so I was telling those who were present in the morning is that I worked so much in labor ward and in ICU. In some of these countries, you work in ICU so much so that if you don't have content, unapelekwa sluice, you become a sluice nurse. So we kazi yako ni kuosha nguo za wagonjwa. Okay, so that's why you must develop this content. In as much as you have the right answer, think about what about these others? What do they cause? Okay, yeah, you don't need to clap. Mnanipea kichwa kubwa, naweza pata.
Thank you, Ojai, for the good explanation. Hope with that explanation tumeelewa vizuri why not the others, and amesema yeye hataki claps. Yeah, so just thank you. Okay, we can continue. Tupate cities. Resilience amesema now you know why you are missing a lot by not attending the morning sessions. Yeah. Ukweli. So purpose to attend the morning sessions, to be well equipped with knowledge. Yeah. So we have the next question. Question number, what is it? Question number 387. Signs of hypothyroidism. You have A, muscle weakness, depression. B, you have tachycardia, irritability. C, we have decreased appetite and tachycardia. And D, we have hypertension and somnolence. I think let me have people tackling question number 387. We have already discussed about hypothyroidism today, so itakuwa ya haraka haraka. So people are going with A. You can also CT. You give A and you same as CT. So let me have the other question. Let me have the other question. Let me have the other question. Thank you. So from the other question, I have question number 388. A patient with potassium levels in excess of 5.0 is considered to be in a state of A. We have hypernatremia. B. Hypercalcemia. I have C. Hypervolemia. Then you have D. Hyperkalemia. And when answering this question, I would like us to say about the normal ranges of potassium, the normal ranges of calcium, yeah, the normal ranges of sodium, of magnesium. Yes. Let me get people typing about it. People are endorsing D, that is hyperkalemia. So, we have a very good evidence here from the mother of evidences. Happiness herself, and saying that the normal range should be 3.5 to 5. So above 5 ni hyperkalemia. So potassium imbalance, that is hyperkalemia, level greater than 5. Here ndio hyperkalemia. Signs and symptoms. Remember murder, that is muscle cramps and weakness, urine oliguria, respiratory distress. D for decrease in cardiac contractility. E for EKG changes, reflexes, that is decreased ETR. So for the EKG changes, we have a peaked T waves. Causes, we have burn or tissue damage. Potassium leaves the cells. We have Addison's, results in hypoaldosteronism leading to potassium retention. Excessive intake, rapid intake of sodium containing solution. Then medications, we have ACE inhibitors that retain the potassium, and the potassium sparing diuretics like spironolactone. You have NSAIDs, then you have decreased potassium excretion from kidney disease, that is dialyzed patient. Treatment, we monitor EKG. If due to excessive intake, stop potassium solution, restrict potassium in diet. If due to increase decreased excretion, potassium wasting diuretics, furosemide, can do a dialysis. Immediate treatment, if EKG changes present, give calcium gluconate, which stabilizes the cardiac, as the membrane, insulin, and glucose to shift the potassium back into the cells temporarily. So I think in treatment in the world for hyperkalemia, we do the binding. So how do we do this binding? People typing there. Functions, we have balances, fluid volume, nerve transmission, heart contractility, and muscle function. That is the functions of potassium. Normal ranges from 3.5 to 5. Potassium and sodium is equals to opposites. So when sodium increases, the potassium will decrease. When the potassium decreases, the sodium will increase. Yeah. Then we have hypokalemia there, signs and symptoms. We say 6 L's: energy, confusion, leg cramps, limp muscles, low shallow respirations, little cardiac dysrhythmias, and lots of urea. That is, we have a T wave inversion rather than the one that we had a peak T wave in hyperkalemia. For the causes, we have poor potassium intake, NPO, fasting, malnutrition, movement of potassium from ECF to ICF, then have alkalosis, any movement of potassium from extracellular fluid to intracellular fluid, alkalosis and excess urine, deletion of serum, potassium, excess water intake, excess fluid with potassium, that is excess potassium loss from potassium wasting diuretics, vomiting, and GT sanction. Treatment, if due to inadequate intake or serum dilution, potassium supplementation, oral IV given, never given as an IV push. Injected potassium rapidly can cause cardiac arrest. Hold potassium wasting diuretics, monitor for EKG, monitor magnesium and calcium levels, often linked together. So with that, we also have the OJ Brand wants to add something. Okay, so OJ Brand, you can unmute and dispense knowledge.
Yeah, that is quite some good evidence from the mother of evidences. Now, there's symptoms of hyperkalemia. You see, they are always totally asymptomatic, and there are hospitals where patients are ever connected to machines, regardless of the state of the condition upon which they are going through. That as the potassium levels increase, the symptoms primarily impact muscular and cardiovascular functions. Things like general fatigue, muscle cramps, and heavy limbs. Things like neurological issues like numbness, tingling, or as pins and needles sensation in the hands and feet. You don't want to eat, you have nausea, you are vomiting, you are having abdominal pain, you are having diarrhea, you are having palpitations cardiovascularly, you're having chest pains, pulmonary, or fluttering sensations. You are also having flaccid paralysis. You are suffering from severe respiratory failure and sudden cardiac arrests. But then, hyperkalemia just doesn't come easy. The kidneys are the most common causes of hyperkalemia because they filter out excess potassium. And if they are failing, then potassium levels get to fill up, especially in cases like acute kidney injury. There's a sudden drop in glomerular filtration rate, and that stops the removal of potassium. Similarly, the chronic kidney disease, especially in advanced stages 4 and 5, which means fewer functioning nephrons are available to clear the potassium. And there are also some medications that are very notorious in the creation of hyperkalemia. So they may be intentionally or unintentionally blocking up the potassium clearance, like ACE inhibitors and like blood pressure drugs. ACE inhibitors, blood pressure drugs like lisinopril and losartan. They suppress aldosterone, okay, and they reduce kidney excretion. There are these spironolactones, potassium-sparing diuretics. They block potassium loss in urine. Be careful when you're taking things like Brufen. NSAIDs reduce kidney blood flow and they slow down the excretion of potassium. And then there are also cellular shifts, like potassium leakage out. So most potassium lives inside cells, but massive cell damage in cases of trauma or chemical or in cell damage or chemical changes, I think they can cause it to flood the bloodstream. And when they do that, number one, there will be tissue destruction, severe burns, physical trauma, or rhabdomyolysis, which is rapid muscle breakdown, and things and such also release massive intracellular stores. When you have metabolic acidosis, when blood becomes too acidic, the cells pull in hydrogen ions. And when they pull in the hydrogen ions, they push out potassium, which leads to hyperkalemia. When you have insulin deficiency, I think we discussed a lot about insulin in the morning. Insulin normally pushes potassium into cells, causing DKA, and this disrupts the process. Now, when you're a nurse, you'll be posted and you're told to take care of the patient who is having hyperkalemia on an ECG or an EKG. So you must understand that as the potassium levels rise, they disrupt the electrical conductivity of the heart. It is more of a, how do I put it? It is more of a classical push and pull visual model described how the EKG trace stretches vertically and horizontally as the severity increases. Because the stages could be, first of all, you can have the early stage where the levels are between 5.5 to 6.5 milliequivalents per liter. And then you look at the ECG, you find that you have peaked T waves. These are tall, narrow, and symmetrically tented T waves. They resemble a sharp camping tent. Okay? When it becomes moderate, as continuation with medications continue, the potassium levels rise between 6.5 to 7.5 milliequivalents per liter. Now, under such a case, T waves are no longer involved, but the P wave flattens and the PR session prolongs. The P wave becomes wide and flat, eventually disappearing. And you find that the PR interval becomes longer. Now, when it becomes severe, now it moves from 6.5 to 7 to 9.0 milliequivalents per liter. Now, we don't have peak T waves or P wave flattening and PR prolongation. Now we have QRS widening. And the main ventricular contraction wave, QRS, widens out as electrical conductivity or conduction slows through the muscle. Now, those can be managed, but when it becomes critical, whereby now it's beyond 9.0 milliequivalents per liter, That is where now we have a sine wave pattern. The sine wave pattern is whereby now the QRS complex merges smoothly with the tall T wave, and it looks as like a smooth mathematical wave. It's a sign of imminent cardiac arrest. So when you are in a panel of interview, and they ask you, how are we going to manage, can you describe for us the ECG changes in hyperkalemia? And you don't know the levels and the stages and how to describe the ECG finding characteristics, then you are in deep trouble. Thank you. You can continue. I hope we are learning.
Sure. Yeah, learning. Thank you for that. Thank you Ojeba. Ojeba and amesema hataki makofi. Uh, thank you. With that explanation, hope tumeelewa vizuri, and I had asked about how we do binding. Someone here talked about the hypokalemia management and using the DICs. Binding we use with insulin 10 IU, 50% glucose, calcium gluconate. Yeah. So with that, we can continue. Let me have some cities. I had also asked about the normal calcium level, yes, normal magnesium level. Okay, Sharon is asking about addicts. Oh, addicts yenye imewekwa A from mama's girl. So you are worried why imeanza na A? I'm also worried kama wewe. I know of dicks, maybe mama's girl can tell us why A. And nimeona pale imeandikwa amesema albuterol. So acha mama's girl explain. Mama's girl, if you are in a position to unmute, you can unmute, and if you choose to type, you can also type. So which one do you choose? I think it's albuterol to salbutamol. Oh, are they in the same class? Yes, they go for the same class. Asking, So let me have the cities. Let me have some cities. So it's Dix, so it's not a Dix. That is Sharon asking. So city. So let me have the next question. Next question. Thank you, Gal Toto. The next question is question number 389. The health message given to a patient following tympanoplasty is the health message given to a patient following tympanoplasty is A. Drink fluids using a straw. B. Avoid blowing the nose and sneeze through the mouth. C. We have administer saline water into the ear to avoid to aid healing. Then D. We have avoid noisy places up to 2 weeks post-operatively. Let me have people tackling question number 389. Let me have people tackling question number 389. Mama's Gas going with B. Falls B. Aggressive B. King is going with B. Sony. So for endorsing B with no any other contrary answer. So 389B, and B says B is avoid blowing the nose and sneeze through the mouth. So can we have an evidence showing nursing care after tympanoplasty? Yes, let me have some evidence. Where is happiness? Yeah. So let me have some evidence. Everyone is allowed to look for evidence and give it here so as we can go through it. Yeah, we have some evidence. Tympanoplasty, I think, is the repair of the tympanic membrane, that is the eardrum. So I need some evidence. And why do we think the others cannot be answers? Like for A, drink fluids using a straw. Yes. Why do we think that C, administer saline water into the ear to aid healing, and then to aid healing, and then D, avoid noisy places up to 2 weeks post operative delivery. Why are there not answers? Kuna mtu ameuliza win ameuliza CD. That's why I'm saying that we need an evidence. And the time is up. So I want us to conclude with this question. So if I would get an evidence, it would be better. Yeah. Or should we give OJ Bryan a chance to explain it better? Because I can see tunajua masaa imeisha happiness. Unfortunately, you're typing that without giving us the evidence. So OJ Bryan, you can explain. Unmute.
Okay, I'll try and do this in the least time possible. You avoid blowing the nose and sneeze through the mouth. For option B, as it is, sneezing or blowing your nose increases pressure inside your eyes. This pressure can push out or damage the fragile new eardrum graft, the patch that was used to fix your ear. And then drinking from straw creates suction. So this, increases pressure. This causes negative pressure in your throat and ears, which can also hurt the healing graft. And then option C, you must keep the separated ear completely dry until your doctor says it's safe. Saline water will increase your risk of infection. And for D, while you should protect your ear from very loud sounds, 2 weeks into the 2 weeks is not the only rule. Pressure control and keeping water out are equally important for up to several weeks. You see, because if you are recovering from such a condition, you avoid also heavy lifting. Do not lift items beyond 5 kgs for 2 to 4 weeks. Straining increases blood pressure in your head and can dislodge the graft. You avoid vigorous exercises because things like running, weightlifting, and aerobics. Stick to light walking until cleared by your surgeon. Air travel, that is a no, until at least 4 to 6 weeks, because rapid changes in cabin pressure can rupture the new eardrum. Now, bending over, keep your head above your heart, because if you need to pick something up, bend at your knees rather than at your waist. Straining at the toilet, use stool softeners if needed, as straining also will increase pressure in your ears. And you, as a nurse, you must also advise such a patient to keep the ear canal dry. Absolutely no water should enter the ear canal until permission is given. And then while showering, you should place a cotton ball coated with petroleum jelly like Vaseline into the outer ear bowl to create a waterproof seal. You clean the external ear shell using a damp, wrung out washcloth, if that is the word, wrung out washcloth, so that you don't let water drip inside. There's nothing like cotton swabs or Q-tips into the ears or any objects that can enter the ear canal. When you're washing your hair, you must make sure that you lean your head backward over a sink or a tub. And you must have someone help you wash your hair while keeping the operated side completely covered and protected. Because if anything happens, post-surgery infection will occur as a foul-smelling drainage, which is yellow, green, or a thick discharge that is coming out of the ear canal. And then there'll be very bad pain because that pain radiates to the brain. In as much as the brain does not feel pain, the meninges will be affected. So you'll be having a deep throbbing pain that increases over time. And it is not relieved by any prescribed medication, unfortunately. And then you can also have high body temperature, fevers of up to 38 degrees centigrade. And then dizziness because of constant vertigo. You have to think twice before standing up because you have spinning sensations and you can fall off, or a sudden loss of balance. So for increased swelling, there will be things like redness, warmth, or severe swelling behind the ear around the surgical incision. I think that is all I can remember. I hope it helps. Thank you.
Thank you for that great explanation. Hope tumeelewa vizuri better. Thank you. And thank you, Toto, for giving us the question. Thank you, Rubikesh, for updating this question. Thank you, everyone, for your evidences. Thank you, the amount of evidences, happiness as well. And with that all said, I would like us to conclude on this and to ingia for unit wise. So we can conclude with maombi. Kama tutaombea huko kwa unit wise, sawa. Okay, wakati mwema basi. I'm ending the chat.